مساء الخير. أنا لما أنواتي. أنا دكتورة بالصيدلة من أمريكا، ونحب نقول لكم أهلا وسهلا بالمحاضرة اليوم. المحاضرة اليوم جاية من سامز فارماسي أسمبلي. هي حتكون واحدة من المحاضرات، عدة محاضرات للعناية المشددة، the ICU course. معظم المحاضرة حتكون بالإنجليزي، بس يمكن يكون في شوية عربي كمان. So our presentation today is titled Between Sleep and Agitation, Sedation and Delirium Pearls for the ICU. And we're very happy and thankful to have our guest speaker, Dr. Ahmad El Ouweini. Dr. Ahmad El Ouweini is a doctor in pharmacy and board certified in pharmacotherapy, and he's also a fellow in critical care. Dr. Ouweini is a clinical lecturer in the pharmacy department in Gulf Medical University in the United Arab Emirates, and also he's a clinical pharmacist and preceptor in Thumbe University Hospital. Dr. Ouweini, thank you so much.
شكرا كثير دكتورة لما. Thank you for your kind introduction. ومرحبا، مساء الخير جميعا. طبعا إلي الشرف أن يكون من أحد المحاضرين بال ICU course أو كورس العناية المشددة بالنسبة للسامس فارماسي أسمبلي. وإن شاء الله بنتمنى نقدم مادة مفيدة ومناقشة يعني غنية إن شاء الله، بما يعني بيطور مهاراتنا إن شاء الله بهذا المجال. طيب let's start. التوبيك تبعنا اليوم حيكون sleep and agitation and pain. Actually, we will go through some basic information first, briefly, and then what the evidence says, and some clinical pearls on how you use the medications in these three conditions. طبعا anyone who works in the ICU knows that sleep, agitation, delirium, sedation, pain, all of these terms, يعني we deal with them on daily basis in our practice in the ICU. Knowing the ins and outs of these is very important to optimize the pharmacotherapy that our patients are receiving on daily basis. These are my learning objectives of this session, and we will start with a patient case. So the structure of this lecture will be, we will start with a patient case, and then we will be going through the material, the content, and then we will end with the same patient case and see how would you answer that case. وبعدين بالآخر حنعمل كهوت fun game, learning, game-based learning. حيكونوا 4 questions, light ones, هيك to just confirm our understanding of the concepts we covered in this session. تمام؟ طيب. Our case here, عندنا elderly woman admitted to the ICU for acute decompensated heart failure and kidney failure. Ejection fraction can less than 30%. فعندنا reduced ejection fraction. She's administered continuous infusion of bometanide, one of the loop diuretics, but the benefit was limited because of the kidney failure. She's intubated in the ICU. And that was because of worsening pulmonary edema and hypoxia. After intubation, she scored 0 on the RAS. Throughout the lecture, we will know what RAS means. CAM ICU was positive, and the BBS, the behavioral pain score, was 4. Normal blood pressure and heart rate. What would be your best recommendation for managing your analgesia, sedation, and delirium goals? Would you initiate propofol? Would you administer haloperidol? Will you initiate morphine? Will you do nothing and just verbal reassurance for the patient? طبعا نعرف كلنا انه ICU environment is full of alarms. ringing alarms, ringing phones, personnel, عندنا nursing coming in and out of the room, عندنا one-to-one ratio usually nurse to patient. She has only that patient that she need to take care of, and she takes a lot of vital signs, blood sugar, finger sticks, repositioning, ambient lighting. مرات اللايتنج بيكون يعني منه comfortable للبيشنتس. room temperature مش كل البيشنتس they tolerate the same room temperature. فكمان all of these lead to unpleasant environment, and all of these will lead to anxiety, agitation, and pain. And especially if patients عندهم baseline low tolerance للpain أو للagitation or anxiety. This will tell us that we want to always shorten the ICU duration as much as possible to decrease the complications that can come from all of these unpleasant environment. هلا المين guidelines اللي هو Society of Critical Care Medicine guideline that we will base our recommendations on هو was published in 2018. Most of the recommendations will come from this. بس طبعا هن as well as 2 months or 3 months back on March 1st, 2025, they published focused update لهال guideline that was published 7 years back. We know that the US guidelines usually take long time to update in many diseases. They wait for many trials in order to update the whole guideline, and sometimes they publish مثلا every 2 to 3 years focused update to the previous guideline. So رح نحكي usually على 2018 هذا ال most solid evidence based recommendations رح يكون plus whenever applicable we will go and get some focused updates from this document that was published by the SCCM 3 months back. Let's start with analgesia in the ICU. The pain طبعا we know it's unpleasant sensory emotional experience. Usually like critically ill adults they experience moderate to severe pain even at rest. لأنه نحن حكينا we have all of these environmental factors that they pass through on daily basis, plus they have a lot of procedures كمان. So procedural pain لحاله can be a significant contributor لهال process. We know we have different types of ICU. طبعا here are some examples: medical, surgical, trauma, and again different type of ICU, different conditions. Complex patient scenarios can contribute to different perception of pain and management of pain. Usually women have more pain after cardiac surgery. They express and report more pain after cardiac surgery, and they report that poorly treated compared للمن. طيب شو هن risk factors for the pain؟ في عنا إذا بدنا نحكي يعني risk factors that make this patient report pain more than the other one. So we have to look at two different categories of the pain: pain at rest and pain during the procedure or perioperative pain. The pain at rest is influenced by psychological factors. في عالم already baseline they have depression, they have anxiety. Also young age, usually they report more pain compared to the older in some cultures, for example. Also, if they have more comorbidities, polypharmacy, whatever, if they have history of surgery and they were exposed to severe pain before, maybe their pain threshold is less. But pain during the procedure is influenced by the procedural pain intensity itself. يعني عندنا different procedure مثلا peg tube insertion, pleural tap, many يعني procedure lumbar puncture if you have any CNS infection suspected, etc. The type of the procedural underlying surgical or trauma, the different diagnoses. Again, younger age female, non-white ethnicity. Usually these report higher pain scores. Uh, why addressing pain in the ICU is very important? Because pain can kill in the ICU. How pain kill? Uh, Pain kills when it prevents the patient from participating in care, and it can lead to complications that may eventually will lead to death. كيف؟ أول شيء let's take two examples. When patient cannot cough because they have مثلا pain in their chest, and they are not reporting this, maybe because they don't like to report pain, or no one is addressing this properly during the patient encounter, during the rounds. When they cannot cough, they will not be able to clear secretions, and therefore they will have aspiration pneumonia. This will lead to respiratory failure, which is already a common condition in the ICU. Also, another example, let's say they have pain in their legs and they are not being properly addressed, so they will not move. And maybe the team, the nurse, whoever, is not encouraging the mobility, masalan, and they are not moving by themselves, so we'll have immobility, and then we will have VTE that can lead to PE or, any serious consequence. That's why addressing pain, although pain by itself is not a disease, it's a symptom of underlying disease, right? So addressing this phenomenon or symptom is very important on daily basis and multiple times per day, in order to make sure that we are not, bypassing or overlooking this important concept. Then how do we assess pain? طبعا we know that if the patient in the ICU can communicate reliably, they can go with self-reporting. The numerical pain scale. This is the reference standard tool for pain assessment. اللي هو نحن بنقول لهم from a scale of 1 to 10, how do you rate your pain? فهون بناخذ انه severe, moderate or mild. في موضوع مهم لازم نحكي عنه هو الفيتال ساينز. طبعا عندنا الهارت ريت, blood pressure, respiratory rate, SpO2. All of these can indicate unaddressed and unmanaged or improperly managed pain. إذا عندنا consistently tachycardia, high blood pressure, وهي ما كانت upon admission, for example, and it's after 1 or 2 days they are there, and we don't have any clear explanation for those abnormal مثلا tachycardia, hypertension, tachypnea, whatever. So or for example, they have more this synchrony with the machine, with the mechanical ventilator. SpO2 will get less, and so these abnormal vital signs can tell us that probably there is an unaddressed pain, and we need to do proper assessment through validated tools. اللي هو مثل ما حكينا عنه، إذا كان البيشنت able to communicate reliably then هنعمل self reporting. إذا لا معناته حنروح على السكيلز that go with the intubated patients أو unresponsive patients. فمثل ما قلنا هدول they are not valid indicators, but they are only cues, triggers to initiate further assessment. طيب طبعا نحن في عنا بالنسبه للبيشنتس who cannot report the pain في عنا شيء اسمه behavioral pain scale او سي بوت. تمام، الكريتيكال كير بين اوبزرفيشن تول. فالبي بي اس او السي بوت، وفي عندنا كمان نون انتوبيتد بي بي اس اذا كان هو مثلا ان كوما بس نون انتوبيتد او وات ايفر، مثلا او he's non intubated but cannot for example let's say maintain the proper interaction with the healthcare provider. We have those skills. What we use in practice mainly CPOT, but also we can also use the PPS. فهن هدول valid reliable pain scales in different ICU settings. للناس they cannot report or self-report the pain. الBPS from 3 to 12 عادة الBPS score of 6 or higher is considered unacceptable pain. تمام. الCPOT range from 0 to 8, 8 being the most pain. أكيد we can also ask the proxy, the caregiver, those who are there beside the patient. This family can also be involved in the pain assessment. طبعا هول you can find them online easy in different medical websites for your reference, and we use them in the daily shifts for assessing the patient. The nurse do them, and also probably in the time before or after the rounds. Always when we speak about pain in the ICU, we should always talk about analogous sedation. Now, analogous sedation means when we deal with analgesia and sedation in the ICU, we should follow this concept. تمام? We have two types of analogous sedation, okay, and two approaches, if you want to call it. The first approach is analgesia-based sedation. Analgesia-based sedation is, or let's say analgesia-first sedation is, we use an analgesic, وطبعا عادة بيكون هو opioids, before a sedative is used to reach the sedative goal. هلا حنشوف when we talk about sedation that we have a certain goal on the RAS, Richmond Agitation Sedation Scale, validated assessment tool for sedation. تمام. When I want to sedate a patient, تمام, first I need to optimize their analgesia, optimize their pain. Okay, so I use an opioid, and then with whatever dosing regimen I have, in order to optimize analgesia. Then whatever is left, مثلا, I give fentanyl 50 or 75 mic per minute, for example. Okay, and then after that, I check the RAS. Okay, I made sure that the BPS or the CPOT is appropriate, and then I check the RAS. If the RAS is not at goal, I give sedative, dexmedetomidine, for example. Okay, so that's the analgesia first. So I use the analgesia dose of the sedative of the analgesic of the opioid, and then I check the sedation tool, sedation score. If it's not within the goal, I use a sedative. Now we have another approach, which is analgesia-based sedation. Analgesia-based sedation is when I use the opioid instead of the sedative. So I start with the analgesia dose of the opioid, and then I check the RAS, or the sedation tool for the goal score. If that score was still not reached to the target, I increase the opioid dose to reach the sedation goal. Not yet, I increase the opioid until I reach the sedation. So here I don't use any sedative other than the analgesic that I'm using, which is the opioid. Clear? So both of them are used, and you can use both of them depending on the patient. مثلا the risk for respiratory depression, liver impairment, many other factors, blood pressure, vital signs that can tell you use this or that. Both are equally effective, but you have to be patient specific. فال SCCM recommendation goes with you need to routinely assess pain and treat pain before a sedative is considered. So we always say this: manage, optimize pain, then you go to assess the sedation. Okay, you cannot sedate a patient who is in pain. Okay, IV opioid is the first line for non-neuropathic pain, which is most of the time it's non-neuropathic pain type of the ICU, somatic or visceral pain. All are equally effective for the opioids. Now we will have a short comparison. Non-opioid analgesic such as acetaminophen or ketamine or for example, NSAIDs also, and many others can be used as adjunct to decrease pain intensity and reduce opioid consumption. And طبعا, we all know the opioid crisis that is happening worldwide. So that's why we will use opioid, but we don't want to overuse it in the ICU. Not only for the patient, benefit in the ICU, but also later in their discharge or transition of care. But when we use adjunct analgesics, we will reduce the opioid consumption, okay? Compared to when we use only opioid, we will give more and more of the opioids to reach the same analgesia goal. Type nifopam is one of the also adjunct analgesic, and it's used as adjunct or replacement to opioid to reduce opioid use. هي بتشتغل على الدوبامين receptor and serotonin peripherally, and the less GI, renal, and hepatic side effect. يعني not like, for example, the non-steroidal anti-inflammatory drugs that we try to avoid them as much as possible in the ICU due to their GI and renal side effects. مثلا الacetaminophen عنده hepatic side effects, so this drug is devoid of these side effects. بس عنده some other problems, CNS problems, such as lowering the threshold for seizures, for example. So you have to be careful when using nifopam in patients who are actively seizing or with a history of epilepsy. طبعا NSAIDs, we try to avoid them, but sometimes we have to use them 1 or 2 doses or for 1 to 3 days, fine, but try to avoid and shorten the duration as much as possible in case you want to use them because of the risk of bleeding and kidney injury. For neuropathic pain, we know that carbamazepine, gabapentin, pregabalin are excellent first line. Also, the one we have duloxetine, venlafaxine, also flaxine as well. And if you want to optimize the pain after cardiovascular surgery, IV opioid, of course, the first line. We don't, as per the SCCM guidelines, routinely recommend IV lidocaine as an adjunct, analgesic. It is there, one of the options as an adjunct, but due to multiple pro-arrhythmic, for example, side effects, antihepatotoxicity, we like to not recommend it as first or even second line. دايما لما we give opioids, we know that we should be proactive on giving laxative and stool softeners, and we will come to this in a separate section. So for the procedural pain, opioids, first line, for example, fentanyl, remifentanil, hydromorphone, morphine at the lowest effective dose. Nitrous oxide or local anesthesia, until now they don't have strong evidence to be used in chest tube removal pain management for that procedure. And we can use NSAID orally or IV or rectally as an alternative to opioid during discrete and infrequent procedure. As not very painful procedure, you can use sporadically, randomly NSAID 1 dose, no problem. For the comparison between different narcotics, طبعا, we have fentanyl, hydromorphone, morphine, methadone, remifentanil, all of these agents. طبعا methadone it's the least used. Maybe in the US they stopped using that in practice because of the long half-life. As you can see, the longest half-life, accumulation, CNS side effect in the elderly, the hepatotoxicity, etc. The most one we use in the ICU is fentanyl, due to the very short onset, very quick, as you can see, fentanyl, and short half-life compared to مثلا morphine. It's shorter than morphine. وعادة fentanyl مثلا we give bolus, and then we give intermittent, or we give infusion. Okay, IV infusion. Most of them we go for infusion, and it has less side effect compared to morphine in terms of hypotension, in terms of skin reactions, hypersensitivity. Why? Because morphine is associated with a histamine release from the mast cells, whereas fentanyl does not carry this risk. That's why hypotension is more pronounced with morphine administration compared to fentanyl. So keep that in mind. طبعا fentanyl batch we don't use it in the ICU, only IV. تمام. Batch comes later in the ward or at home on the ambulatory care setting, because a batch will have continuous release, where in the ICU might be dangerous in case patient develop any side effect of fentanyl. Even if we remove the batch, the patient will still experience continuous release of the drug transdermally. Avoid batches أكيد in the ICU. Also, so we discussed about the less hypotension with fentanyl, so it's our first line. Morphine, we use it, but it comes as second line. Hydromorphone is a therapeutic option in patients tolerant to morphine fentanyl. It accumulates in hepatic renal impairment. And the advantage of remifentanil is really when you have severe hepatic impairment, severe renal impairment, someone who has hepatorenal syndrome, end-stage liver, end-stage kidney disease, and you want to use opioids, your agent is remifentanil because it's not metabolized with the liver or by the liver and not eliminated by the kidney. تمام. It's eliminated by the plasma esterasis. بس طبعا remifentanil only as infusion. طيب. Now, regarding the opioid induced respiratory depression. Okay. طبعا opioids, they have multiple side effects. One of them, and the most serious one, is respiratory depression. Everyone who gets opioid will develop respiratory depression. أكيد لا. So there are risk factors that increase the risk for respiratory depression. So when one or more, so the more of these risk factors are present in one patient, means you have to be very careful in the initial dose of opioid, in how you titrate it. You titrate it very slowly, etc. So those who are using concomitantly benzodiazepine or other sedatives, that increase the risk of respiratory depression. هيدا one risk factor. كمان those who have sleep apnea also, those who are obese, those who have chronic COPD, those who are smoking, heavy smoker, those, of course, who has advanced age more than 65, and for example, those who have directive that prevent rescue. So, for example, DNR, do not intubate, do not resuscitate. Those patients are كمان at high risk, because even if that happen, we will not intervene in this specific subset of patients. What do you do for those risks? Titrate in smaller increment, as I told you. Give opioid more frequently instead of larger doses. يعني instead of giving مثلا, if you are giving not infusion, this applies to the intermittent. If you are giving morphine مثلا 5 milligram, or let's say 10 milligram every 8 hours, لا, give it 5 مثلا every 6 hours, better than giving 10 every 8 hours. So every dose will be smaller but more frequent. Use patient control analgesia. That was shown to be less associated with respiratory depression in alert and clinically stable patients, and ensure continuous use of pulse oximetry, which is there always in the ICU. طبعا here some opioid equivalent for your own reference. We need to touch base on one concept, which is cross tolerance. Cross tolerance can happen in the ICU patients receiving opioid. مثلا, patient was on morphine, eye infusion, and you want to shift to fentanyl, مثلا because of side effects or shortage or whatever reason is there. هلا tolerance can quickly to develop. Let's say tolerance developed للمورفين عند هذا البيشنت before he started developing the side effect مثلا, and you need it to increase. Tolerance means you need to use higher doses to achieve the same analgesic effect. When you are shifting from morphine ل fentanyl or hydromorph, whatever you want to use, start usually طبعا you have here what you have here equivalent, right? don't go with the same equivalency. يعني مثلا he was receiving 10 milligram every 8 hours. Don't go with fentanyl 10 microgram, 100 microgram every 8. And don't go immediately to the same equivalent dose, especially if the patient was on the opioid for 3-4 days, where tolerance may have developed. Why? Because they may need lower or higher doses. So patients may respond differently with a pharmacodynamic to those patients, pharmacodynamic of those opioids. So that's why go to lower than the same equivalent. مثلا go to 80 or 75 and then increase. لأنه دائما أنت anyway you are assessing the pain score using the BPS, CPOT, whatever you're using. So that's a concept and a pearl to use in your practice. But طبعا, how do you titrate the opioids? You increase the dose by 25 to 50% in moderate pain. In severe pain, you go more faster. طبعا هون we are not talking about patients who have risk for respiratory depression. We're talking generally. Reassess pain in every dose interval. When the opioid does not last enough, long enough, you increase the dose. مثلا you make it from PRN to intermittent to standing intermittent, from standing to continuous infusion. طيب نحكي عن something very important when we talk about the opioid induced constipation. This is extremely important because something serious, something happening in almost all of the patients who receive opioid, they will develop this. So here they مثلا patients without cancer receiving opioid. لأن نعرف the cancer patients chronically they receive opioids يعني because of the severe pain associated with cancer. بس عم نحكي those who don't have cancer up to 60%, and I read some papers say up to 70 or 80%. It may present immediately يعني in the same day or مثلا the next day, or it can take some time gradually. مثلا patients will start the bowel movements will start to decrease day by day. Once they develop this constipation, okay, it will be very difficult to have optimal relief. Regardless, بغض النظر شو أعطيت 1 or 2 or 3 agents, he will not get back to normal easily. It will take time. And many patients will stop the drug. يعني هلا هون عم نحكي طبعا على outpatient basis مش على ICU. ICU they don't have the any privilege to do that. بس إنه this is something serious that will annoy patients a lot. فهون the concept, whenever we have a patient on opioid, make sure when you are checking the medication every day, you know, whether you're pharmacist, whether you're physician or nurse, make sure you see also a laxative on the patient chart. Okay. What type of laxative? طبعا we most commonly we go with stimulant like Senna or Bisacodyl. With or without you can add stool softener. تمام. Like Ducozate. او فينا كمان نعطي اكيد polyethylene glycol as osmotic. هلا stool softener alone is not really enough for established cases. They can work for preventing constipation, but again I would go with stimulant or osmotic alone, fine, but stool softener alone لا. It has to be combined with either stimulant or osmotic. هدول the non-narcotic analgesics that we have. We discussed about ketamine, acetaminophen, NSAIDs, and for the neuropathic pain, gabapentin, carbamazepine, or pregabalin. For your information, طبعا again the concept is have multimodal analgesia. So not only opioids, go with others to achieve pain faster, reduce the tolerance of the opioid, and reduce the consumption of the opioids. So you have a pain consult as pharmacist مثلا. How would you approach this? وحتى الphysicians أكيد when you face persistent pain in the patient, ask who is the patient, why are they here, identify the patient's comfort goal. Very important. Don't expect that you will reach والله 0 or 1. لا. Yani we don't want that, and patient will not, and we should set that very clearly, with the patient. We will not reach no pain, okay, but we will reach what pain is comfortable, what pain scale is comfortable for the patient. Some of them will tell you 2 or 3 or 4, I'm fine with this, okay. You have to set with the patient and agree on what goal is good for them, and you target that with and you manage your medications accordingly, and identify how the pain is interfering with the goals of care. Remember the slide, how pain kills in the ICU? You need to discuss this very importantly and openly with the patient and with the nurse who is observing the patient very frequently, how he is participating in his goals of care, like moving, immobility, whatever. And determine the mechanism of pain again. So have multimodal approach, somatic, visceral, neuropathic, give different pain medications. Some common reasons for uncontrolled pain. ممكن we are not giving adjunct, only opioid. This is one reason. Give adjunct. We are giving suboptimal adjunct with the dose or whatever. Sometimes the opioid itself, we are not giving enough breakthrough. We are very good at prescribing the basal of the infusion, but breakthrough of the PRN, we are not giving enough. That's something very important. Usually there is a rule that the breakthrough should be 10% of the dose of the the single dose of the standing or of the long acting. تمام. فهير for example, patient is getting 80 twice daily. فقد ايه عم ياخذ باليوم 160. So 10% of 160 is 16. So he should get 16 or at least 15 milligram every 8 hours. Here is getting only 1/3, 5 milligram every 8 hours. Okay. فنحن بنحسب قد ايه عم ياخذ باليوم كله. بعدين بناخذ 10%. قد ايه عم ياخذ باليوم من اللونج اكتنج. بعدين بناخذ 10%. وهذا ال 10% يكون هو السنجل بريك ثرو بي ار ان دوزنج. واكيد we should always as an interprofessional team communicate with the nurse. Maybe they have misunderstanding of the orders, a long acting, breakthrough, infusion, whatever. Maybe they are anxious about complex order, whatever. So that's also something we need to address. طبعا هناخد the questions at the end inshallah. Proceeding with the sedation. تمام. طبعا a non-pharmacologic strategy for the sedation is to improve the patient comfort. We should work on the lighting, music, massage. طبعا هدول كلهم non-pharmacologic. Verbal reassurance, avoidance of sleep deprivation. بنحاول نخفف قد ما فينا مثلا blood test at the night, vitals, whatever, as much as possible. Patient positioning based on their preferences. The goal of the sedation is to tolerate physical environment, optimize patient comfort, prevent effects of stress, and avoid self-extubation. Those who are on the invasive mechanical ventilation, removal of the catheter lines, the central line, the Foley catheter, كل هدول, alleviation of the pain. Also, again, remember, because before optimized sedation, patient should be optimized for the pain, facilitate nursing and management as well بالنسبه للكير. طيب over sedation. فهون نحن when we want to optimize sedation في عندنا over sedation وفي عندنا under sedation. Over sedation will lead to respiratory depression if we give too much of sedative, hypotension, bradycardia, increased time on the ventilator, increased time in the ICU, as well as the cost per night. صح؟ والmedications وكل complications. Under sedation is ما بنعطي enough sedation. البيشنتس حيكون agitated, tachycardic, hypertensive, صح؟ Ventilator asynchrony, hypoxic. He will be very agitated, so we will put restraint, physical restraint. Accidental extubation can be also and patient injury, as well as psychosis. هلا حنحكي كمان عن psychosis with delirium that can happen because due to untreated sedation مثلا. فالvariables that will help determine which appropriate sedative is the pain control. Is it optimized ولا لا؟ هي before. إذا عنده previous history of substance abuse. This is very important على فكرة. نحن ممكن يجي عندنا patients he's addict ل او dependent مثلا على بنزودازيبين او addict لكوكايين او هيروين او whatever وبيجي ب symptoms of withdrawal whatever you do بالنسبه للsedative he will still be severely agitated so you have to take a different path. الناس اللي عندهم baseline neurological functions dysfunction sorry mental status كمان dysfunction history of seizure activity كمان هذا بيقلنا انه how deep we want to go with the sedation مثلا dementia psychiatric history لانه many of the sedatives have these side effects فهذا بخلينا نعرف how far we can go with the dosing and how fast we go in our titration. blood pressure heart rate respiratory rate لانه many of the sedatives هلا حنشوف بيعملوا bradycardia hypotension and respiratory depression وكمان depending on the cardiac renal hepatic gastric pulmonary pancreatic issues وكمان اذا عم ياخذوا بالبيت اني بنزودازيبين لانه ممكن اذا حدا على بنزودازيبين وجاي ووقفناه حيكون very agitated بينما لو كملنا البنزودازيبين that he was taking at home he will need less doses of the sedative. حكينا عن اذا كان عنده smoking antidepressants ممكن يكون withdrawal فاني medication he was on at home we should resume it okay لحتى ما not to add another factor to help him agitated okay to make him agitated فنحن we want to help him get relaxed with the least amount and duration of the sedative تمام. المين recommendation هو انه we want the always light sedation versus deep sedation so always go for light rather than deep level of sedation. ليش؟ الديب ليفل رح يخليهم more يعني deep sedated رح يضلوا اكثر على mechanical ventilation وبنعرف mechanical ventilation كل complications of that come with the mechanical ventilation such as الVAP ventilation associated pneumonia dependence respiratory failure that their lung become dependent and all the others with infections and neurological كمان لانه mechanical ventilation بده يكون sedated حتى brain function will take longer time for rehabilitation صح that's why we like light sedation except in some conditions ما فينا نروح light لازم نروح deep هنحكي عنهم in the next slide. level of sedation should be assessed every 2 to 4 hours or consider assessing every 4 hours during night time يعني during the day عادي فوت على المريض كل ساعة كل ساعتين بس night time خليهم to have good quality sleep so every 4 to 6 hours fine. وطبعا احنا دائما بنعمل daily sedation interruption or spontaneous awakening trial و spontaneous breathing trial SBT SAT ممكن تكون by the physician او nurse protocolized يعني nurse driven protocol تمام هن بيعملوا هالشيء and they report to the physician. فاذا ليش بنعمل الديلي sedation interruption نحن we want the brain not to depend on the sedative تمام اذا خلينا الفنتانيل ماشي او دكس ميدوتوميدين ماشي بروبوفول ماشي دائما continuous خلص their brain is almost dead يعني خلص تعود عليهم ما في electrical activity very minimal بينما لما نوقفه for few minutes during the day هيك we allow the brain to regain its function allowing and facilitating extubation and weaning off down the road. Same spontaneous awakening spontaneous breathing trial we turn off the ventilator كمان every day we see how the patient will respond agitated desaturated etc. كيف شفنا السي بوت والبي بي اس او numerical rating scale بالبين هون عندنا الساس sedation agitation scale او الراس as well هدول هن الموست validated we target RAS of -1 2 + 2 وهدول الساس will rise for your own reference. فالكارديك surgery the recommendation to use propofol over benzodiazepine in mechanically ventilated patients. In all other patients, we use not cardiac surgery. In cardiac, the strongest evidence with propofol. In others, we either propofol or dexmedetomidine because both of them will provide lighter sedation compared to benzodiazepine in mechanically ventilated patients. تمام. حكينا هذا الشيء لانه lighter sedation, shorter mechanical ventilation, length of stay, and increased physiological stress but not high incidence of MI. شو يعني هي؟ نحن البيشنتس لما ما بيكونوا deeply sedated رح يصير عندهم النورمال physiological stress، يعني النورمال ريفلكسز، هارت ريت، تاكيكارديا، hypertension whatever. فهذا healthy. We want this. معناته البيشنت is responding. بس الديب سيديشن رح يخلي حتى هذا it will blunt it. تمام. ف that's one of the benefit to make the patient easier transitioning to extubation soon. هلا النيو جايد لاين الفوكس ابديت صار حتى in favor of dexmedetomidine over propofol. هذا اللي published 3 months back I told you this year. ف they suggest use dexmedetomidine over propofol. ليش؟ لانه بيعطي lighter sedation وحتى عنده less incidence of delirium. تمام. Compared to propofol, depending on multiple studies that came after 2018 up to 2025. تمام. فهذا النيو ريكومنديشن، اما هذا كان الاولد ريكومنديشن in 2019. فاذا البيشنت ما بده deep sedation and not in cardiac surgery is still propofol. Not in cardiac surgery and not candidate for deep, go for dex if possible as a first line. طبعا كل السيداتيف agents they have the respiratory depression except dexmedetomidine. خلينا نتذكر هي البيرل. dexmedetomidine ما عنده risk of respiratory depression like the one we see with others, benzodiazepine and propofol. هلا propofol dexmedetomidine عندهم الهايبوتنشن براديكارديا very severe. فذاتس واي وي افويد حتى البولس دوزز معاهم بالنسبه للسيديشن، بنروح دايركتلي مع الانفيوجن. البروبوفول عنده البروبوفول بريس بروبوفوليتد انفيوجن سيندروم، هي لما بنستعملها for more than 48 hours at rate more than 50 mic per kg per minute. ف we should be careful مع البروبوفول. We will come to this. فالبروبوفول نعرف انه وات سولوشن، عنده soybean glycerol اجيول. صراحه انا two main take home message I want you to take away. اول شيء monitor triglyceride مع البروبول for sure and once it reach 800 stop propofol. Okay. طبعا هاي in my institution. Other institution might go higher or lower threshold. تمام. لانه it can increase triglyceride significantly وهون you can risk pancreatitis if you exceed the 1000. غير هيك propofol we used to say for a long time don't give it for someone who has egg allergy or soybean. بس هذا طلع misconception. ليش؟ لأنه عادة ال patient who are allergic to the egg هن بيكونوا allergic للإيج بروتين اللي هو الوايت، بياض البيض، بينما اللي موجود بالبروبوفول هو اليولك بالصفار تمام. فنو بروبلم. كمان ما في مشكله اذا حدا عنده صويبين الفول الصويا الرجي. واي؟ لانه الموجود بالبروبوفول هو الاويل، بينما عاده اللي بيكون عالم عندهم الرجي للصويبين للبروتين تبع الصويبين مش للاويل بحد ذاته. فكمان no problem. So these are not contraindication for propofol. For the sake of time I will skip these. One thing to remember, zinc supplementation should be considered in patients at high risk of zinc deficiency. يعني حدا عم ياخذ propofol and they are in septic shock, burn أو large volume diarrhea, please supplement zinc with them, especially إذا عم تاخذوا propofol and you know you are using it more than 4 to 5 days. تمام؟ لأنه حيصير عندهم zinc deficiency which can compromise the immunity of the ICU patients. You know, he already compromised due to the ICU stay and all the stress. طيب خلينا to skip these for the sake of time. Dexmedetomidine طبعا the slides you have them as PDF in the chat. You can come back to the slides, and if you have any question later you are more than welcome to contact me. I put my contact information at the end. Dexmedetomidine هذا صار هلا مثل ما شفنا الفيرست لاين light sedation. It may facilitate extubation. ليش؟ لأنه ما عنده respiratory depression مثل ما قلنا. Patients بيكونوا عادة 0 or +1 or -1 يعني بيكونوا almost arousable. الشيء كويس فيه انه عنده analgesic property by the way، بس منه enough، يعني عادة منه enough، بس بيساعد بالانالجيزيا. عادة do not titrate more frequently than every 30 minutes لأنه بده وقت لياخذ. So إذا عملت more frequently more than 30 minutes حتروح ب overdose. ف every 30 minutes you can titrate لأنه بده 30 minutes to see the peak effect. اوكي. اوكي هي احكي لها اذا patient عنده severe hepatic failure it can go to can have longer duration. So you اذا انت عندك patient عنده severe hepatic failure use a lower starting dose and titrate more slowly. حكينا انه loading dose don't give usually during the ICU sedation. فيك تعطيها للسيرجري intraoperatively، بس إذا حدا ICU sedation don't give loading of Dex or propofol due to the risk of bradycardia and hypotension. إذا حدا عنده acute decompensated heart failure or advanced heart block أكيد ما تعطيه لأنه قلنا بيعمل severe bradycardia هالبيشنت. ما في drug dependency بس ممكن يصير withdrawal symptoms. الأوبيويد حنروح very quickly. fentanyl أكيد titrate no more frequently than every 30 minutes. No ceiling dose. You need to taper it slowly if you use it for more than 7 days. And when you are tapering it, use enteral oxycodone enteral through the NG tube or PEG tube لحتى تعمل bridging. انت عم تعمل وينينج للفنتانيل عم تعطي كمان انترال اوبيويد. مثل ما قلنا ما بنفضل مورفين وهيدرومورفون لانه عندهم هالريسك اوف هيستامين ريليس هايبوتنشن اند سكين رياكشنز. بنزودازيبين هذا اللي عم نكون عليه. امتى بنحتاج الديب سيديشن اللي هو in other words بنزودازيبين؟ لما بكون عندي ستاتس ابيليبتيكس، alcohol withdrawal, post cardiac arrest especially بالtargeted temperature management. بنكون بدنا we want to deep sedate the patient post cardiac arrest، بدنا نقلل الميتابوليك demands، بنروح deep sedation. benzodiazepine dependence او withdrawal. تمام. هدول don't go for Dex, don't go for propofol, go for deep. هدول لازم you go for deep for benzodiazepine. وطبعا ما في ceiling. hypotension is more concerned in pediatric. ما في داعي هون withdrawal. اذا البيشنت ما كان عليه بالبيت don't worry لانه انت ما حتستعمله لمونثs بالاي سي يو. So إذا patient عنده high risk of respiratory depression use with extreme caution. يعني البيشنت لازم يكون intubated إذا عنده risk of respiratory depression لما بدك تبلش الميدازولام. Lorazepam, the same thing. Lorazepam, what you need to remember in the IV, it contains propylene glycol. هذا one of the excipients. هذا ممكن يعمل renal failure or lactic acidosis إذا أعطيته more than 48 hours. So consider limiting the use of lorazepam to 48. If not, monitor clearly the renal function. Alprazolam. There is a rule إنه replace alprazolam with alprazolam. يعني هذا اللي البيشنت ممكن ياخده بالبيت كان للانسومنيا وات ايفر واجا بالمستشفى وقفنا له اياه بالاي سي يو غلط. كونتينيو لانه اذا وقفت له اياه وبلشت له حتى الهايست دوزز اوف ميدازولام هي ويل نوت بي كنترول. او برشت له بروبوفول هي ويل نوت بي كنترول. بدك كثير هاي دوزز. ف to avoid the high doses and the deep sedation, continual alprazolam along with the IV infusion sedative حتحتاج less doses and less time on the ventilator. تمام. last section هو الديليريوم. الديليريوم عندنا short one. شو يعني ديليريوم؟ طبعا acute onset change of mental status, fluctuating course and ability to focus. It's associated with increased mortality, prolonged ICU stay and hospital length of stay. تذكروا اول سلايد قلت لكم يا الانفايرمنت واللايتنج والالارم وبفوت عندك كثير دكاتره وكثير نيرسز وفارماسيست ومدري شو، فلحالها it can cause delirium يعني. وبنعرف نحن على فكره في شيء اسمه بوست اي سي يو كلينيك ريهابيليتيشن كلينيك. تمام. الاي سي يو ممكن تعمل منتال تروما على فكره بدون اي شيء compared ل other يعني stay in the world. That's why delirium is very common. وحتى بتاثر على المورتاليتي كمان، مش والله انه فذاتس عندنا شيء اسمه بوست اي سي يو كوجنيتيف امبيرمنت. شو الريسك فاكتور؟ في شيء فينا نحن نتحكم فيه as healthcare professionals such as reduce the benzodiazepine dose as much as possible. عرفتوا ليش كنا عم نقول we prefer Dex or propofol compared to benzodiazepine in the sedation. Reduce blood transfusion. نحن already عندنا cut off of 7 of blood transfusion for most of the patients. reduce these. ومش بس هيك، كمان على فكره في drugs that can cause this like corticosteroids. They can lead to delirium كمان as well. So في عندنا non modifiable، هي ما فينا. Those who have advanced age, baseline dementia, prior coma, pre-ICU emergency surgery or trauma, والناس اللي عندهم already high baseline Apache معناته severely ill، فهدول كمان high risk of delirium. الدراجز اللي نحن ممكن نشتغل عليهم انه نقلل او نبدل البنزودازيبين. those that have anticholinergic تمام نحاول نقللهم. كورتيكوستيرويد ما قلنا. ف شو الريسك فاكتور for corticosteroid induced neuropsychiatric؟ مثلا daily prednisone of 40 or more او equivalent من other steroid, hypoalbuminemia, underlying psychiatric disorder and BBB damage, promethazine, diphenhydramine, metoclopramide are drugs. H2RAs مثلا use PPIs instead of H2RAs for the SUP. These drugs are to substitute or discontinue. الفاليديتد سكيل هن كام اي سي يو او اي سي دي اس سي تمام. You can use either. Both of them are excellent, are validated. You assess it at least every 8 to 12 hours and you write it in the medical chart. I will not go through the CAM ICU for the sake of time. You can refer back to it. هي بتعملها nurse ممكن physician as well. You ask some questions, basic questions. مثلا squeeze my hands when I say the letter A in this sentence or in this word. بتسأله will the stone float on water؟ يعني مثلا السؤال هو بديهي بس انت ممكن يكون هو ما عنده organized thinking وهيك. The best way is to prevent. درهم وقاية خير مقنطر علاج، صح؟ ف the best way is to prevent. early mobilization whenever possible to reduce incidence and duration of delirium. Use of pharmacologic agents is not recommended to prevent. لا. كل شيء non pharmacologic. Don't give drug to prevent. Combo of pharmaco and non-pharmaco is not recommended. Control the light, noise, clustering, all the activity at the day. حتى الزيارات كلها during the day، ما في at the night. ما حدا يفيقوا during the night، هي كلها بتقلل delirium. Good quality sleep can prevent delirium. طيب لو صار delirium كام ICU positive we have to treat. عندنا multiple agents. الفيرست جنريشن هالوبريدول، وفي عندنا الاتيبيكال انزابين، ريسبيريدون، كيتايابين، زيبراسيدون. طبعا كلهم بدنا ننتبه على الاي سي جي، ممكن يعملوا كيتي برولونجيشن، اكسترا بيراميدال syndrome تمام due to blocking of dopamine can happen. اذا عم ياخذوا ميتوكلوبراميد as well maybe as a prokinetic in the ICU ممكن يعمل major interaction مع الانتيسيكوتكس، ممكن يعمل neuroleptic malignant syndrome. So you have to avoid this if possible. هلا شو صار في updates بهذا الموضوع؟ صار في major updates من ال 2025. شوفوا ب 2018 كانوا عم بيقولوا we suggest on the right of the screen we suggest not routinely using haloperidol or any atypical antipsychotic. هلا شو قالوا بال 2025؟ we are unable to issue a recommendation. So هن كانوا against صاروا neutral. هذا بدلنا انه صار في new trials that showed some benefit. وليش عم اقول انا some benefit مش strong some benefit of antipsychotics whenever we have clinically diagnosed delirium using one of these two tools. تمام؟ لانه كان في benefits, some of them even mortality benefits of haloperidol او atypical antipsychotic. بس الديزاين of the trials و many confounders خلت انه we are not very much convinced. ف You can or you cannot use it. بس الصراحه بنعرف انه in practice we use haloperidol, we use antipsychotics. تمام. هلا الشيء الثاني we suggest using rehabilitation mobilization. هي ضلت مثل ما هي، بس هون ما كان في شيء على الميلاتونين. بنعرف الميلاتونين هذا الاندوجينس هرمون اللي بيساعد على السليب كواليتي. كان في نو ريكومنديشن. هلا الميجر تشينج صار وي سجست ادمنسترينج ميلاتونين. تمام. فهلا هذا صار ممكن تعملوه از بريفنشن. تمام. وبس الفكره كانت انه ما في سبيسيفيك دوز، لانه كثير كان في فرايتي بالار سي تيز اللي اشتغلت على الميلاتونين، فما في سبيسيفيك دوز للميلاتونين. بتعرفوا انتم في او تي سي، في بريسكريبشن وكذا، وفي عندنا طبعا نحن الراميلتيون اللي هو السينثيتيك فورم اوف ميلاتونين. we can use that one. So الراميلتيون is more of unified of standardized dosing. الميلاتونين ما عنده specific dosing yet، بس البوتtom line use this or this. The recommendation is to use it to prevent delirium. I will end my presentation with this A B C D E F bundle. This is very common checklist that we use in the ICU. Assess, prevent, and manage pain. Both SATs and SPTs, spontaneous awakening, spontaneous breathing trial. Choice of sedation and analgesia depending on the patient. Delirium, assess, prevent, and manage. Early mobility and exercise دائما to prevent delirium. And family engagement and empowerment ليساعدوا بالrecovery during and after the ICU admission. Okay, with that I come to the end. طب خلينا نرجع نشوف الكيس. طيب هلا بدي your interactions probably by typing on the chat. خلينا نشوف شو رايكم. رح نرجع للكيس اللي بلشنا فيها وبعدين حنعمل كهوت وبعدين we will end. اول شيء عندنا هالالدرلي وومن رح اذكركم فيها acute decompensated heart failure، عندها low ejection fraction، عندها kidney failure، she is intubated. هذا كله فاين، بس اللي بيهمكم انتم هو تشوفوا الفيتال ساينز وتشوفوا السكورز. الراس she scores 0 on the RAS، هذا تبع السيديشن. البي بي اس اللي هو البيهيفير بين سكيل she score 4. تذكروا شو قلنا significant BPS start from which score. الكام ICU is positive for delirium. طيب so what would be your recommendation؟ هل حنبلش بروبوفول to do the sedation؟ هل بدكم نبلش هالوبريدول treat the delirium؟ هل بدنا نبلش مورفين to treat the pain or to address the pain؟ ولا ما نعمل شيء only offer verbal reassurance؟ What do you think? A, B or C? Hello, while I'm sharing, I'm not able to see the chat, but maybe if someone can read the answers for me or what they are answering.
So far, there are no responses in the chat.
Okay.
To encourage people to respond. What I would say is B, haloperidol. And D might be also effective.
Yes. So, do we have some answers now?
Yes, we have B as in boy.
Okay. So, yeah, thank you, Dr. Lama. So that's, yes, the correct answer. طبعا, since the CAM ICU is positive, so we should go with B. We should go with haloperidol. خلاص. It is there, we should treat it. And as we said, whenever it's there, we will offer the pharmacologic treatment. Haloperidol is good here. We don't have any contraindication, at least from the information we have from the case with this patient. So we give it, and we give it as needed. Propofol, no need, لأنه الRAS is 0, which is our target. No need to put propofol, and we keep monitoring the RAS. Whenever it's out of target, we initiate the sedative. وحتى if we want to initiate the sedative. هلا we will keep propofol depending on the heart rate, blood pressure, and if there is an AV block, if there is acute decompensated heart failure or not. So whether propofol or dex, that can come later. هلا ال pain scale is 4. Remember, هي 3 to 12. 6 and above is significant and unacceptable. You need pharmacological intervention. 4 is fine. So you really don't need morphine for a BPS score of 4. Okay. So that's really the correct answer. Thank you everyone who answered. So these are my contact information. You can contact me for any question you have on the session and beyond. And then
بتشكر كثير دكتور أحمد الأويني على المحاضرة. يعني كانت كثير مفيدة محاضرة، وفيها كثير معلومات مهمة ومعلومات دقيقة. شكرا كثير دكتور الأويني، وشكرا لحضوركم.
شكرا دكتورة رنا، يعطيك العافية، ولا دكتور ماهر ولا كل التيم، وإن شاء الله كان في فائدة، وإن شاء الله بنشوفكم probably next week in the next session إن شاء الله.